First, credit where it is due. These guidelines was led by doctors, plus a true multidisciplinary dream team that includes cardiologists, emergency medicine doctors, hospitalists, interventional radiologists, vascular medicine specialists, pharmacists, nurses, and even patient representative. These guidelines covers everything from the moment the patient walks into the emergency department until 1 year later. We're talking real-world adult pulmonary embolism care, diagnosis, the brand new risk categories, who goes home, who stays, anticoagulation, advanced therapies, and long-term follow-up. It is practical, patient-centered, and multidisciplinary, exactly what we need in 2026. Here are the game changers. Number one. Number one, the new American Heart Association and American College of Cardiology categories from A to E replace the old submassive and massive labels with precise actionable buckets. Category A, incidental and asymptomatic pulmonary emboli. Just you can safely send home from the emergency department. Category B, symptomatic but low risk by the Pulmonary Embolism Severity Index or HESTIA criteria. Early discharge is now standard. Both of these are class of recommendation 1, meaning strong recommended. Top take home message, part 2. Continue the hints. Category C through E. Patients get admitted. Activate your pulmonary embolism response team, PERT, early. Advanced therapies are now reasonable for category E1 and should be considered for D1 through D2. That is class or recommendation 2A. Low molecular weight heparin beats unfractionated heparin. Direct oral anticoagulants beats vitamin K antagonists. And most first-time pulmonary embolism patients without a major reversible trigger should stay on standard anticoagulation beyond 6 months. Finally, screen for chronic thromboembolic pulmonary disease at every visit for a full year. These are the rules that will define the 2026 practice. The paradigm shift, why new categories, quick history lesson. The old 2011 to 2019 schemas left too many patients in gray zones. The 2026 version finally integrates clinical severity scores, biomarkers, right ventricular imaging, hemodynamics, clot burden, and respiratory status. Result? Far more accurate prognosis and crystal clear treatment threshold. This is the biggest practice changer in pulmonary embolism care in 15 years. Here is the centerpiece of the entire guidelines. Image 1 shows the full A to E table. A is green, lowest risk. E is red, highest risk. You have subcategories B1 and B2, C1 to C3, D1 and D2, E1 and E2, plus the R, respiratory modifier whenever oxygen is low or respiratory rate is high. Memorize this grid. It will guide every decision you make from now on. Category A, incidental, asymptomatic pulmonary emboli, found on a computer tomography scan done for something else. Cancer staging is the classic example. There is no symptoms, no right ventricle strain. You can discharge this patient straight from the emergency department. Anticoagulation is still decided case by case, but hospitalization is not needed. This is a single change will free up countless beds in the hospital. Category B. Patients are symptomatic but still low risk by the Pulmonary Embolism Severity Index. Simplified Pulmonary Embolism Severity Index or HESTIA criteria. B1 is subsegmental, B2 is segmental or larger. These patients can go home early with a direct oral anticoagulant study in the emergency department and close follow-up. Data from multiple randomized controlled trials and meta-analysis show 30-day adverse events under 2%. This is safe, evidence-based outpatient pulmonary embolism care. Category C. We have the symptomatic with elevated scores on either right ventricular strain or abnormal biomarkers, or both in C3. Add R if they are hypoxic or breathing fast. These patients get admitted and watched closely for the first 24 to 72 hours. That is the danger window. Hospitalization allows us to escalate quickly if they deteriorate. Category D is the pre-shock zone. D1 is transient hypotension that fixes with fluids. D2 is normotensive shock. Think elevated lactate, rising creatinine, or low cardiac index. These patients need intensive care unit level monitoring, and we should strongly consider advanced therapies. Lactate is your key lab here. Category E is the highest risk, persistent hypotension with cardiogenic shock or full cardiac arrest. E1 gets advanced therapy as reasonable. E2 is a refractory shock. This is where pulmonary embolism response team, PERT, teams shine and where mechanical support and embolectomy can be life-saving. Respiratory modifier R. Any category can get an R added if oxygen saturation is below 90%, respiratory rate is 30 or higher, or they need significant supplemental oxygen. It tells you the respiratory component is driving the problem. This simple letter changes your ventilatory strategy and escalation plan. Clinical evaluation algorithm. Start with symptoms, do a good history and physical exam, pretest probability, low probability, use the pulmonary embolism rule out criteria, intermediate, D-dimer plus years criteria, high, straight up to imaging. This algorithm safely rules out pulmonary embolism in most low-risk patients without unnecessary scan. Clinical assessment. Class of recommendation 1, level of evidence A, always starts with the target history and throughout physical examination. Asks about surgery, cancer, pregnancy, hormones, prior clots. Look for fast heart rate, low oxygen, and leg swelling. These steps alone dramatically improve your pre-test probability and prevent over-testing. D-dimer strategies. Class recommendation is 2A. Use agent-adjusted D-dimer or the years algorithm. Failure rate is under 2% at 3 months in larger trials. This is how we safely avoid computed tomography pulmonary angiography scans in the majority of low to intermediate risk patients. It is one of the highest yields rules in emergency medicine right now. Pregnancy adapted years. For pregnant patients, the pregnancy adapted years algorithm is a class recommendation 2B and reduces computed tomography pulmonary angiography use by 65% in the first trimester, with failure rates near zero. This is a major win for radiation safety in our pregnant patients. Diagnostic imaging, core recommendation. Class recommendation is 1 if pretest probability is high or the D-dimer is elevated. Image then. Computed tomography pulmonary angiography is the go-to test because it finds peripheral emboli, show right ventricular strain, and gives you an alternative diagnosis. Imaging in pregnancy. In pregnancy with normal checks X-ray, low radiation dose computed tomography pulmonary angiography is reasonable and often preferred because it is fast, widely available, and give extra information. BQ spec versus planar. If you're if you're doing a ventilation perfusion scan, use single photon emission computed tomography. Class recommendation is 2A. It is more reproducible, lower radiation, and more specific. Alternative imaging. When a computed tomography pulmonary angiography cannot be done, ventilation perfusion scan beats magnetic resonance angiography. Magnetic resonance angiography is still inconclusive too often. Lower extremities ultrasound. Image 3 and 4 shows a normal versus thrombosed popliteal vein ultrasound. Ultrasound class of recommendation is to be only order it if symptoms are present or it will change management. Routine ultrasound after negative computed tomography pulmonary angiography adds nothing. Echocardiography, not for diagnosis. Echocardiography is a class recommendation 3. No benefits for diagnosis pulmonary embolism. It is not sensitive or specific enough. Save echocardiography for risk stratification after you have confirmed the diagnosis. RV assessment. Always report the numerical RV assessment by CTPA. Always report the numerical right ventricle to left ventricle ratio on computed tomography pulmonary angiography. Class recommendation is 1. A ratio of 1 or higher predicts worse outcomes. Echo, RV dysfunction parameters. Right ventricular enlargement and McConnell's sign when you do echocardiography reports everything. Right ventricle to left ventricle ratio. Tricuspid annular plane systolic excursion less than 1.6 centimeters. McConnell's sign, tricuspid velocity greater than 2.6 meters per second. Class recommendation is 1. This is how we risk stratify. Risk stratification, clinical scores. A low risk, class recommendation 1. Use Hestia criteria, pulmonary embolism severity index, or simplified pulmonary embolism severity index for categories A and B. These scores are excellent at identifying safe outpatient candidates. For higher risk patients, for stable category C and D patients, pulmonary embolism specific score like BOVA or composite pulmonary embolism shock are reasonable. Class of recommendation is 2A, but they are not perfect predictors of deterioration. Excuse me. National Early Warning Score or its updated version may be used for serial monitoring in category Cs and D. They are dynamic and easy to repeat in the bedside. The NEWS and NEWS2 as an alternative. Hemodynamic assessment. Look for normal tensive shock in category D2 using lactate, creatinine, and cardiac index. A mean arterial pressure below 80 millimeters of mercury in category C3 is a red flag for escalation. The biomarkers measure troponins or brain natriuretic peptides in category C and lactate in category C through E. Lactate adds powerful prognosis information beyond cardiac biomarkers alone. Thrombus burden and chronic features on CTPA. Report chronic features like web or bronchial dilatation. They flag patients at future risk for chronic thromboembolism, pulmonary disease. Hospitalization decision. Simpler rule. Categories A and B can go home. Categories C through E stay in the hospital. Activate your pulmonary embolism response team, PERT, early for D and E. Initial anticoagulation. Low molecular weight heparin beats unfractionated heparin for the initial parenteral start. Class of recommendation is 1. Direct oral anticoagulation beats vitamin K antagonist for oral therapy. Class of recommendation is 1. Anticoagulation duration 3 to 6 months initially, then extend beyond 6 months for most first-time pulmonary embolism patients without a major reversible trigger. Class recommendation is 1. Role of IVC filter. Inferior vena cava filters have a very limited role, mainly when anticoagulation is truly contraindicated. Advanced therapies overview. This image shows a mechanical thrombectomy device. These therapies are now on the table for D and E. Systemic thromboembolism. Systemic thrombolysis is reasonable for category E1 and can be considered for D. Class of recommendations to A. Highest benefit in persistent shock. Catheter, direct, and mechanical thrombectomy. Lower bleeding risk than systemic lysis. Growing role in deteriorating intermediate and high-risk patients. Surgical embolectomy, used when everything else fails or is contraindicated. Mechanical circulatory support, extracorporeal membrane oxygenation, ECMO or Impella, right pump for refractory category E2 shock. Post-acute PE management, follow up in 1 or 3 months and screen for chronic thromboembolic pulmonary disease at every visit for a full year. Patient activity and travel guidance. The guideline give clear advice on when patients can return to exercise and fly safely. Recurrent PE management. Reassess the entire regimen, intensity, duration, and underlying cause. Persistent symptom patients do not just say it's post-pulmonary embolism syndrome. Evaluate systematically for chronic thromboembolic pulmonary disease or other causes. Evidence gaps and future direction. We still need better dynamic tools, clear advanced therapy triggers, more pregnancy data, and real pulmonary embolus response team outcome studies. Tables 2 and 3 give you the class of recommendation and level of evidence framework and all the clinical decisions ruled out in one place, while table 4, 5, and 6 are your quick reference for right ventricle parameters, risk schemas, and evolution, and all are the scoring systems. So print the guidelines. And these are just other slides.